So, good morning to all of you joining the Cake and Pie Expo 2.0. I'd first like to express my gratitude for being invited to such an event. It's very exciting to be part of this international forum. As we can tell, the Expo is very innovative, and that goes nicely into the theme of our session this morning. We're going to be talking about the cornea, the ocular surface, but many of the innovative aspects in both a positive and sometimes less positive light. So it's very early over here in Belgium, where I'm speaking from, so I thought it would be more appropriate to pre-record my video. So I'm going to start with my own video, but I will be also followed up by other colleagues, Dr. Christopher Starr, Dr. Dagny Zhu, and Dr. Dmitry Pavlenko, where we will all be discussing different new interesting innovations in our field. So thank you very much, and let's kick off this session. Good morning. My name is Professor Sorke Migou from the University of Antwerp, and I'm very privileged to be with you at the Cake and Pie Expo 2.0. What I would like to talk about today is how can we afford it? High-tech corneal medicine in a changing world. And I have no financial interest in any of the products or medications we discuss. So I want to take you through 3 examples of trying to make the highly expensive a bit more affordable for our patients. When I talk about expensive medications, I mostly mean this growing innovation in the areas of these advanced therapies. In Europe, we have a special designation for these advanced products, and that's across the globe. There will always be a sub-definition of medicinal products that go above and beyond the normal pharmacological means. Advanced therapeutic medicinal products, or ATMPs in Europe, consist of all those advanced therapies, those really innovative treatments, like treatments that correct patients' DNA, treatments that add mRNAs, gene-correcting cell therapies, CAR T treatments, diseased cell replacement options, and in cases of treating or preventing disease by adding cells. These are more than just your average pharmaceutical, and they are, as a result, a little bit less trusted in the pharmacological space and certainly far more difficult to produce. What is the most important thing about the current state of affairs in ATMPs? All of these advanced innovations are profoundly expensive. Why are these new medicines so expensive? Well, typically they come from a lot of extensive R&D, although a lot of this is done at the university level. So you could argue that it's not the companies themselves paying this, but there are certainly huge amounts of money dedicated to research and development. Clinical trials for these types of medications are very expensive too. And most importantly, manufacturing has to be to an extremely high and meticulous standard. All of the steps need to be validated over and over again, and these are higher standards than typical pharmaceutical agents. After you give these treatments, additional monitoring is required, and many of them are for orphan pathologies where there is not a huge patient base, so a large amount of effort is put in for very few cases. And from time to time, you'll have a bad actor like Martin Shkreli who just wants to increase prices on drugs. So this means for the average clinician, we're seeing more and more expensive treatments. If you look in our own field, we have one of the most expensive treatments here, which is Luxturna. This is a gene therapy, but the price per treatment, it is a once-off treatment. Well, you've got 2 eyes, so it could be twice. In Belgium, this is 365,000 euro. It's not exactly a treatment that's extremely affordable to the average person, regardless of where you're living globally. The next problem comes in the form of stem cells. And even at that, stem cells that reach the market and get into patients' eyes can be extremely disappointing. This New England Journal article outlined some poorly processed stem cells that were injected intravitreally that led to a really bad outcome. So quality controlled manufacturing in these treatments mean that they have to be produced to a profoundly high standard. That means money, and that means expense. So I want to bring you to 3 examples of alternative options where we can maybe save a buck or 2. Let's look at the corneal epithelium. And in the last 2 decades, there's been a lot of development in stem cells for corneal epithelial limbal stem cell deficiency. We know that the normal cornea generates its own epithelial sheet by regeneration from the limbus. But in cases of burns or chemical injuries or many other indications, you can have profound vascularization of the cornea due to the failure of the corneal epithelium. Cultured limbal stem cell products can make a huge difference here. And these are two patients that have been treated in my center with cultured limbal epithelial grafts. In fact, limbal epithelial grafts were one of the very first ATMPs in ophthalmology to be approved. We take a biopsy of a patient, we send them to Italy, cells are cultured and sent back to us, and they can result in wondrous improvements. But again, let's look at this price. This is €91,000, 637. Ha, they probably could have rounded it up to 640 at those prices, but okay. What I find profoundly interesting here is that we can do this. This is reimbursed in Belgium, but there's a neater and cheaper option that's used across the globe, which is SLET. This is the simple limbal epithelial transplantation, where something very similar, a biopsy of the good limbal niches on the contralateral side is taken and directly implanted on the other side on a basement of amniotic membrane. Okay, amniotic membrane can be a little bit expensive in some situations, but we're not talking €90,000 expensive. So this is significantly cheaper. And there are emerging comparative studies to say that it can have also an extremely good effect. So this is one area where ingenuity in the surgical room has led to a cheaper and more accessible treatment for patients in need. I want to take the second example to be the endothelium. And this is very exciting as well in the last decade, because techniques that culture limbal endothelial cells are emerging and becoming more reliable. The biggest problem we have with corneal endothelial disease is a lack of donors to meet the global needs. By culturing a donor, you could stretch one to multiple or even hundreds of patients in the best situation. And the leader and landmark paper on this is from Japan in 2018, and it is the accumulated work of the master in this area, Shigeru Kinoshita. He proved that therapeutic administration of cultured cells can work. You can culture these cells and administer them in an intracameral injection after preparing the descenates and get the patient to lie downwards. At the moment, this is also considered an ATMP. So even though we know these cells can work and function, they're extremely highly regulated. So they're not yet to the commercial space. When they first arrive, I think they're going to be quite expensive. So is there something else we can do for patients if we don't have enough donor tissue? Well, there's also the area of non-tissue related interventions. This is a DSO or DWEC, where a central decimetorexis is performed to remove the pathological cells, and the residual endothelium is left to grow to close the wound. This is a patient of mine who had a DSO about 5 years ago and remains extremely happy with her visual acuity and is completely independent of any cortisone treatment for any graft. So if you pick the correct patient, and it has to be a patient with central Fuchs and good residual endothelial cell number, you can really get a wonderful outcome, and you see more and more of these cases being reported. In the long term, they may eventually need endothelial keratoplasty, but certainly as a temporizing or multiple year treatment option, I think is extremely attractive. But can we boost endothelial cell growth in situ without adding a cell product? We maybe can. Here's a product called Repasudil, which is a ROCK inhibitor, which is available across Asia, but not yet in Europe, but we hope soon, which can also promote the growth of endothelial cells, which are really not thought to grow very well at all. But if you combine this with DSO or DWEC, you can improve the cells that grow to cover the defect. So again, this raises the possibility of treating a Fuchs patient with no tissue. Another possibility in the endothelial space is the EndoArt, which is an artificial endothelium. My experience is that it's particularly reserved for cases that are resistant to other biological options. And I'd like to show you a video of a patient who I've given it to. And this is a patient who's had multiple previous rejections of the PK and also of subsequent DSECs to try and revitalize the PK. We take the old DSEK away, we clean the posterior stroma, and here's the artificial endothelium. You can see you can touch it, which you cannot do with an endothelial graft, and you isolate the F side so you know the orientation is correct, and you can just push it into the anterior chamber. We lift it then with gas, and we place one suture to fixate it. Now, this is likely to be of best effect in certain cases. It may not be necessarily what you would use for a mild or early Fuchs, but initial investigations prove to be very promising, and certainly in cases that are highly likely or prone to rejection, perhaps an artificial device could be interesting there. You see the endoart being sutured into place, and it's extremely thin. And what it does is create a watertight seal over the posterior stroma so that it doesn't swell, while the anterior stroma is dehydrated. And I think you'll be seeing more about this in the future for the right indications. My third example here is the space of corneal nerves. We know that neurotrophic keratopathy can be a very tricky disease to treat. These patients tend to respond very slowly, or if at all. The current treatment gamut includes lubricant drops, bandage contact lenses, tarsorrhaphies, Botox, but they can be quite frustrating, and sometimes an amniotic membrane is required to cover them up. In this space, there's been an innovation recently, Sened German, which goes under the marketing name of Oxervate, which is a nerve growth factor, which replaces deficient nerve growth factor on the corneal epithelium and has been clinically proven to promote closure of these tricky epithelial defects. It looks wonderful and it acts very effectively. The main problem, or last time I looked into administering this, is that it was €32,000 for a month in Europe. And if you look at the list of most expensive drugs in the US, here we are at number 5 with $48,000 per month for the treatment. This is out of the reach of most patients. So is there something else we could do for these patients? And I want to show you one more intervention, which is neurotization. This is a treatment whereby we move the nerve axon from a functional nerve, for example, the great auricular nerve, and divert it via a conduit to the cornea so that we can actually bring the axons back to re-innervate the cornea. This has really been on the upswing since about 2009. There's a few centers that currently do it, and I'd like to show you quickly a video of the procedure in our center. So we don't immediately have access to Oxervate. This is a patient who had an extensive tumor removal, which resulted in corneal anesthesia. He had been attending regularly for epithelial defects, painless, of course, in nature, but erosive thinning. And he was at a Mackie grade 3 just prior to having a perforation. He'd been treated with the normal treatments, patching, covering amniotic membranes. So we decided to take a further step to neurotize the cornea. We're creating 4 corneal pockets because we want to bring the conduit right up to the sclera so that it doesn't become dislodged. And we want to implant it into these corneal pockets. The nerve we choose to use in this case is the great auricular nerve of the ear, and to connect it via a conduit. But there are also possibilities to do a direct innervation, for example, for the contralateral infraorbital. But here we chose to perform the conduit exercise, and the sural nerve was harvested. The sural nerve is a nerve of the leg, which has a very limited innervation area, and it's often considered for these conduit nerve transpositions because the pathology associated with loss of the sural nerve is not that high, and it is a wonderfully long nerve to connect our great auricular ear nerve to our cornea. The only downside with it is a little bit chunky, so you have quite a large, thick nerve to work with. The sural nerve is brought in through the inferior conjunctival fornix. It's embedded underneath the conjunctiva, and we bring it towards the cornea and plug it in. Meanwhile, at the ear, it is coaptant directly with the great auricular nerve. This results in the patient having some ear numbness and some leg numbness, but it does improve corneal sensation. It improves corneal moisture, the epithelium improved as well. And the nice part about it when it works is that it gives a persistent effect as opposed to a temporary drop effect. So this is us trying to pull the nerves through. The tip of the nerve with this device is a little bit crushed, so we need to cut that. The nerves in the conduit are not actually the nerves that will supply the cornea. The nerves in the conduit will die, but axons from the great auricular nerve will make their way through over a period of a few months and make it to the cornea. And we've been quite encouraged by early results. And while this is extensive surgery, this requires a multidisciplinary team, it's still considerably cheaper than nerve growth factors. So it's something that we can consider. So what is my take-home message here? Well, how will we afford the newest treatments? Well, for me and my practice, for many years, we won't be able to. Governmental structures are going to increasingly regulate what we can spend or what will be reimbursed for patients. And sometimes ophthalmology can be led a little bit by the wayside because cancer, pediatrics, extremely urgent cases will take priority. So for many people, these advanced treatments, while they may appear miraculous, will remain out of reach. I'm an optimist, so as technology improves, I think they will become cheaper. But I want to stress in the interim, there's still space for wonderful areas of clever creativity and cheaper options. People have seen CLET and they've developed SLET. People have seen these cell cultures, but they've also developed alternatives, cheaper options. And the surgical room can just be as innovative as the laboratory. I want to thank you very much for giving me your time and your kind attention. If you have any questions or you'd like to be in contact, here is my contact information. And I'd like to also add, in the University of Antwerp, we do accept corneal fellows if anyone is interested. Thank you very much. Okay, so thank you very much for your attention. We will now go on to the presentation of Dr. Christopher Starr, who will be talking through the ins and outs of keratoprosthesis placement.
Hi there, my name is Dr. Christopher Starr and I'm from the Weill Cornell Medical Center in New York City. I'm talking about K-Pro controversies today, and the title of the talk is Keratoprosthesis as a First Corneal Surgery. Is it heresy or is it heroic? You decide. Now, these are my financial disclosures, and I can assure you that none of these companies who I consult with and work with have really anything to do with keratoprosthesis or earn any money from keratoprostheses. So this is a case presentation first and foremost about a real-life patient who was referred to me for ostensibly what was severe pseudophakic bullous keratopathy in her left eye. This was an 80-year-old female who had light perception visual acuity in her left eye, whereas her fellow eye was 20/40 and doing quite fine. She was referred for basically a corneal transplantation after what I was told was complicated cataract surgery and multiple quote-unquote IOL surgeries thereafter. On examination, she had a very malpositioned anterior chamber intraocular lens. Her pupil was irregular and peaked. There was some iridocorneal touch, as well as ACIOL touch to the corneal endothelium. Her cornea had full thickness scarring, really opaque cornea, significant edema, significant epithelial bullae, and 360 degrees of pretty hot corneal pannus. She said that she remembered a history of herpetic keratitis, but she wasn't completely sure. And her anterior chamber was just simply filled with vitreous, and there were little strands to the corneal wounds. But she did deny any history of glaucoma or any retinal problems. She's never had glaucoma or retinal surgery or has been treated for either of those conditions. And she had a good tear volume and a good eyelid closure, and there was no exposure of the ocular surface. Of note, and you may be wondering why on earth am I even mentioning this in a case history, but this patient did have a very significant head tremor that really, while she was awake, was persistent and pretty severe. And she also, upon questioning, said she would never in a million years be able to wear contact lenses. She tried in the past, but simply could not use them. So that's the history. What would you do to manage this patient? Well, one might argue, don't do anything. The patient is 80 years old. She sees well in her other eye. She's doing okay vision-wise. Why subject her to a big surgery? Well, she and her family, her daughter who was with her, were both very motivated to do something. They wanted something done. She was very unhappy with the outcome of her left eye and really felt like something needed to be done. And the referring surgeon was also very motivated for me to do something to help her. Well, what about DALK? Would DALK be a reasonable thing to try here? I would say definitely not. Her endothelium is shot, completely gone. What about a penetrating keratoplasty? Well, possible, but with her scenario, multiple surgeries and poorly seated ACIOL, severe corneal pannus, a possible history of herpetic keratitis, vitreous in the AC to the cornea, she's a high risk for a PK rejection or failure early on. She also has a severe head tremor, which would make suture management very difficult in the office. Usually I remove these sutures selectively in the postoperative period at the slit lamp, but when the head is moving continuously, that would be very challenging. But also the patient said she could never and will never wear contact lenses, and as we usually, in most people's hands, certainly in an academic center where I work, these patients with PKs tend to do much better with contact lenses after surgery. Well, what about endothelial keratoplasty? I just said her endothelium was fried, so should we just replace the endothelium with a DSEK? Most likely in this case, since it's so complex, DSEK would be a better option than DMEK, but I would argue neither of them are particularly great choices because the cornea is already scarred through and through, and I really don't think if we replace the endothelium that the cornea is going to magically deturgesce and become clear again. I think it's just too far gone at this point. Also, it would be very complex surgery through small incisions with the vitreous in the AC and ACIOL that's poorly seated. These things would be very, very challenging with DSEK. But also, and there's a high risk in this patient for the need for a rebubbling procedure in the early postoperative period. And again, doing that in an office setting when the patient is awake and with a severe head tremor would be virtually impossible. So, after considering all those options, I thought, well, how about keratoprosthesis? This is a surgery I have a lot of experience with. I have done it as a primary corneal procedure in many patients who did quite well. And so I thought that is probably the best option. And here is why. Usually when we do K-pros, at least at Cornell, we remove lenses, whether they're phakic or pseudophakic, we remove the lenses and leave the patient aphakic. We always combine that with vitrectomy with the help from our retina colleagues. These patients don't have any astigmatism postoperatively because it's an artificial cornea. There's no need for RGP lenses or fitted contact lenses of any kind. Yes, they wear soft contact lenses, but they sleep in those. They don't have to put those in each day. Which again, this patient said she simply would not be able to wear a contact lens afterwards. There's no need for suture management at the slit lamp because, again, there's no astigmatism. These patients tend to do very well. They have very rapid visual recovery when the retina and the optic nerves are healthy. And this patient said she has zero history of retinal problems or glaucoma problems. PBK, herpes, keratitis, corneal neovascularization, keratoconus and ectasia are all low-risk categories for keratoprosthesis. things like pemphigoid, Stevens-Johnson, those tend to be much higher risk for K-Pro and K-Pro complications, but this patient didn't have those things. Similarly, glaucoma is one of the most common causes of irreversible vision loss following keratoprosthesis. And someone with advanced glaucoma, you probably wouldn't want to jump to a keratoprosthesis at this stage. But again, this patient came in with a history of no glaucoma drops ever, and her IOP was normal at that first visit. She's also of an older age, she's 80, so even if her optic nerve was somewhat cupped, very low risk of her losing vision or going blind anyway from post-K-Pro glaucoma in this situation. And again, the patient is very motivated, the family is very motivated, and very importantly, and one of my biggest criteria for pulling the trigger on a keratoprosthesis in anyone is, are they compliant with their drops, with their visits? And this patient was very compliant. That is a very important criteria in assessing people for keratoprosthesis. So, is a primary K-Pro even a reasonable indication for this patient, or any patient for that matter? Traditionally, in the early days of K-Pro, the indications were someone had to have had 2 or more failed corneal transplants, often 3, 4, or 5, before jumping to a K-Pro. They had to have a poor prognosis for repeat graft survival. They had to have perfect tear film and complete lid closure, and they had to have visual acuity of 2200 or less in both eyes before proceeding with keratoprosthesis. And of course, it was only done in one eye, and the second eye would only get a K-Pro if the first eye failed completely or the eye was lost and completely blind. In the more modern era, as we've gotten better and better with K-Pro, and we've learned more, and we've been able to combine with other things, the modern indications for K-Pro are much less stringent than those K-Pro indications I just mentioned. It can be a primary procedure if the patient is at a high risk for PK failure. Why wait? Why do a PK just to say we did a PK, it failed, and if you know it's going to fail before doing it, why do it? So it doesn't make much sense to me to subject an 80-year-old to that. If there is exposure or there are eyelid abnormalities and incomplete blinks and things like that, K-Pro can be combined with tarsorrhaphy to decrease exposure. And, it can be done bilaterally these days. And this is a photograph of a patient of mine, a Vietnamese patient of mine who actually had K-Pros in both eyes that I gave him, and he did quite well. And in his case, binocularity was restored with the bilateral keratoprosthesis. So it can be done. Is primary K-Pro as a first corneal procedure heresy? I would say no, but others would disagree. But there is some evidence in the literature that a primary K-Pro can work quite well, and in many cases better than doing it after a failed penetrating keratoplasty. This is a paper from my good friend Tony Aldave and his group at UCLA, and they showed very good outcomes, and in fact better outcomes, better visual outcomes in patients who had primary K-Pro versus those who had K-Pro following failed PK. Tony Aldave and I also published a case series of corneal keloids, and in my patient who I presented in this paper, I'm about 15 years post-operatively for this young man who had corneal keloid, and I did a K-Pro in a virgin eye. He had a PK in his other eye, which failed almost immediately from recurrence of the keloid. You can see in the photograph there, completely opacified cornea from the keloid. And 15 years on, he's still 20/20 uncorrected in the eye that I did the K-Pro in, and no signs of glaucoma or optic nerve damage. So it can work quite well in the right patients. This has been generating a lot of press fairly recently. This was an editorial, a point counterpoint that I wrote in favor of K-Pro as a first corneal procedure, and this was published in the Ocular Surgery News magazine in 2019. So back to this patient. I thought K-Pro was a great option, the best option for this patient, and I really thought I was going to take this patient from light perception 1 minute to 20/20 the next minute, and I was going to be hailed as the hero. Is it heroic or heresy? I would say in this case, heroic. Now, normally with patients who I'm going to do surgery on at Cornell, I have a team I often work with for keratoprosthesis, but almost always that involves a retina specialist. In the case of this patient, it was Dr. Szilard Kiss, one of my colleagues at Cornell. But this patient, and this is the first time this has ever happened, but the patient came in and said, and this patient actually lived quite far away from my office, and it took several hours for her to commute to the office. And so she had her own ophthalmologists closer to home, one of which was a retina specialist. And she said, oh, here's a note from my retina specialist. And it says here, this is the actual note, sort of saying, I did a B-scan, her retina is attached, everything's fine, go ahead and perform your keratoprosthesis. So I thought, even better, even more of a hero, I'm saving her an extra trip to the city, New York City, to see my retina specialist on a separate day. We already have a B-scan, her retina's fine, as she said, there's no history of retinal problems. Wonderful, let's go to the operating room. And that is what we did. And here we are in the operating room. And this is, in the beginning of the keratoprosthesis surgery, we always, take the cornea, try to find the cornea and see what is going on the inside of the eye. And here we are taking out the ACIOL, and the first thing you can see here is, wow, the ACIOL, the haptic of the ACIOL was through and through the iris, impaled through the iris and dangling into the vitreous, and this is why that ACIOL was so poorly positioned and touching the cornea. It somehow ended up stabbing through the iris. Go figure. Then, after a bit of work, we got the anterior chamber treated, the ACIOL removed, the iris trimmed. Almost always do iridectomies in these patients to ensure that the iris doesn't end up in the visual axis afterwards. This is a titanium backplate, Boston keratoprosthesis type 1 with a titanium snap-on backplate in the smaller sort of pediatric size. We sutured it in. It looked great. We always do a side L test at the end. Side L negative, wonderful. Let's move on to what's often just a kind of perfunctory, quick and easy vitrectomy by our retina specialist. So I hand it over to Dr. Kiss, and he puts his lens on the eye, and this is the first thing we see. And as you can see there through the keratoprosthesis, a very complex, very chronic, very gnarly retinal detachment, and a pale optic nerve, and retinal hemorrhages, and so on and so forth. And the only thing I could hear from my colleague, Dr. Kiss, was a big grunt and a head, his head uncontrollably was doing this, shaking his head, and he looked at me, shaking his head just like this, and we both sort of, slunked in our seats and thought, oh no, this is not good. And so this case took a very long time, a lot longer than we anticipated. And as he's trying to repair this retina, all of a sudden we find this. What is that? That's a Prolene haptic impaled into this chronic retinal detachment. So, yes, I knew that she had a history of complicated cataract surgery, but boy, oh boy, I was not expecting a piece of a Prolene haptic to be through penetrating through the retina. So that was a surprise to all of us. And this case took many, many hours between the K-Pro portion of it, teaching trainees, residents, and fellows, K-Pro and suturing and all of that, and then this surprising retinal complex retinal detachment. The surgery took many hours, and we were quite certain that the visual potential was not going to be great in this patient, unfortunately. And we were correct. In the post-operative period, the vision really never improved better than count fingers. It looked great at the slit lamp. Look at that beautiful K-Pro, the beautiful sutures, but the vision very poor. And so what are the morals of the story? Well, primary keratoprosthesis as a first penetrating corneal procedure, I believe, is perfectly appropriate for the right patient. I thought this patient was the perfect patient for this, but I was duped by the handwritten letter saying the cornea, or the retina, was attached and healthy. So the moral there is, don't trust anyone who you don't know, who you don't work with. Don't trust outside assessments. Only do it yourself or your trusted colleagues in your office or in your department. Get your own retinal evaluation, B-scan, and other tests prior to pulling the trigger on Boston keratoprosthesis surgery. And with that, I want to thank you for your attention. I hope you enjoyed this case.
Yeah, I think we can all identify with some of those ups and downs of complex surgery. So we're a little bit tight for time, so we're going to jump immediately on to our next speaker, which is Dr. Dagny Xu, and she will be talking about Intacs rings and the management of keratoconus.
The title of my talk is Battle of the Bulge, When to Consider Cross-Linking Intacs or Both as Frontline Treatment for Keratoconus. I have no relevant financial disclosures. When it comes to surgical treatments for keratoconus, we've really come a long way. We now have interventions that can improve the corneal shape and curvature, as well as halt progression of the disease. We even have refractive adjuvant therapies that can further improve vision in keratoconus patients. But when it comes to treating the underlying disease of keratoconus, cross-linking has really become first-line treatment for many surgeons. The goals of cross-linking are simple. It is to improve tensile strength of the cornea and thereby arrest progression of keratoconus. Of note, cross-linking was not designed to improve vision, although in many cases it may. When we look at the cross-linking outcomes in literature, we see that it can induce corneal flattening, although mild. The average change in max K was about minus 1.7 diopters in the pooled clinical trials. But we do see that almost a third of patients did decrease their max K up to 2 diopters or more. Corneal flattening, however, doesn't always correlate with a refractive change. Based on this study, we can see that the decrease in spherical equivalent and cylinder, though present, were relatively mild. And similarly, the visual acuity change is usually minimal with cross-linking. In this study by Hirsch's group, we see that most patients didn't gain any lines of vision. However, there were a number of patients who did gain 2 lines or more, showing very variable outcomes when it comes to cross-linking. Now, while we know that cross-linking is an excellent intervention for halting the progression of the disease, is it always the go-to treatment? Well, what about keratoconus patients who are stable and have no signs of progressive disease? What if those patients desire maximal visual improvement? And how about those patients with really steep or irregular corneas who no longer tolerate contact lenses due to poor fit, and those who have lost significant BCVA due to advanced disease? And of course, there are always those patients who are simply not candidates for cross-linking. Those include patients with thin corneas, prior herpetic infection, severe corneal scarring, and those with risk factors for poor healing, like a history of autoimmune disease. While many surgeons have really considered cross-linking to be first-line treatment, and Intac surgery or intrastromal corneal ring segments have really fallen out of favor, I would argue that there is still a place for Intac surgery in keratoconus treatment. Now, the goal of Intacs is simple: to improve topography and corneal shape and thereby improve vision. Of course, Intacs were not designed to arrest progression of disease, but now with more data and more time, we see that Intacs may actually lead to stable outcomes over time. Here we have a study looking at 10-year follow-up after Intacs segment implantation. And in these 36 eyes, the improvement in visual acuity, as well as the decrease in maximum K value, remained significant and stable even up to 10 years, showing that there is likely some role of Intacs in halting or stabilizing keratoconus. And so both cross-linking and Intacs seem to slow the progression of keratoconus, though cross-linking much more so than Intacs. And both cross-linking and Intacs improve vision, though Intacs much more so than cross-linking. And so when I'm presented with a keratoconus patient in clinic and I need to decide on which approach to take first, I like to consider a number of factors. For one, for younger patients with progressive disease, especially those with low levels of myopic astigmatism and still pretty good BCVA, I like to begin with cross-linking. Now, patients who are older and have more stable disease, especially those with more advanced disease and poor BCVA or high numbers, especially those with poor contact lens fit, and those who really desire maximum improvement in their vision, I like to turn to Intacs first. And so whether you choose one or over the other really depends on whether your goal for the patient is to arrest progression or improve vision. So here's a recent case that I saw, a 14-year-old young man with decreasing vision due to keratoconus. He was becoming contact lens intolerant and was no longer able to play sports. His uncorrected visual acuity was relatively poor, and his best corrected vision was only 2100 in the right eye and 2040 in the left eye, with significant myopic astigmatism. So which approach would you take first? When we look at the list of factors to consider, we see that this patient has a combination of both. He's a young patient with progressive disease, but he also has very advanced disease with high myopic astigmatism, poor BCVA, as well as contact lens intolerant. And his real main goal is to improve his visual acuity so that he can play sports again. And so because I really wanted to improve his quality of vision or his quality of life and his functional vision, I decided to proceed with Intacs first. Here we see his preoperative topography with advanced cones in both eyes, especially that right eye. So I proceeded with bilateral Intacs surgery with double segments in each eye, and I inserted the segments at the steep axis based on his refraction and topography in both eyes. Post-operatively, this patient did remarkably well. We can see a huge improvement in his uncorrected visual acuity, as well as a huge decrease in his myopic astigmatism and best corrected visual acuity. This patient was absolutely ecstatic along with his parents. He's playing sports again, and he's talking about getting his driver's license and even joining the military one day. Here, this picture, this topography really tells the whole story. You can see normalization of corneal curvature and flattening of the cornea after Intacs surgery, especially in that left eye. Of course, I will be watching this patient closely for signs of progression because of his young age, at which time I will consider performing cross-linking surgery. And so that leads us to the question, does sequential Intacs plus cross-linking at a later time provide an additive effect? Based on these two prospective studies, the answer is likely yes. Both of these showed that performing cross-linking several months after Intacs resulted in further gains of vision, as well as improvements in spherical refraction, cylinder, and K values. Now, when it comes to sequential procedures, is performing Intacs always the best way to go, or should we be doing cross-linking first, followed by Intacs? This prospective comparative randomized study was done to address this exact question. And they looked at every outcome from visual acuity to corneal curvature to refraction. And when it came to every outcome, greater improvement was found for Intacs followed by cross-linking. And so now it's generally accepted that when sequential surgery is performed, it's generally done with Intacs first, followed by cross-linking. What about performing simultaneous Intacs and cross-linking on the same day? Does that also provide an additive effect? Based on these two retrospective studies, the answer was likely no. These studies actually showed that the Intacs group had better outcomes than the combined group, and the second study showed no significant differences between the two groups. However, when we look at higher quality studies like a meta-analysis, this paper showed outcomes comparing three groups, simultaneous versus sequential with cross-linking first versus intacs first. And they didn't find a significant difference when it came to best corrected vision or uncorrected vision and cylinder. But when it came to spherical refractive errors and the flat K, they actually found greater improvement with the simultaneous group. So simultaneous may be the best route to go. However, shortly after, about 1 year later, Hirsch's group conducted a large prospective randomized trial looking at this exact same question, and his group actually found no difference between simultaneous and sequential intacs and cross-linking. And so the jury is still out on whether simultaneous or sequential procedures are best. So in summary, both cross-linking and intacs slow the progression of keratoconus, though cross-linking more so than intacs, and both cross-linking and intacs improve VA, though intacs more so than cross-linking. And both simultaneous and sequential procedures, intacs and cross-linking, are safe and effective. But for those patients who cannot undergo both procedures and you had to choose one, I'm hopeful that this list or algorithm will help you make that decision. And it really comes down to deciding what the main goal is for that particular patient, whether it is to arrest progression or improve vision. And these are my references. Thank you so much for your time, and it's been an honor to participate in this symposium.
That was a wonderful presentation, and I think it gives us a lot to think about the spectrum of options available for our keratoconus patients. So it is also my pleasure to introduce our final speaker who will be speaking live. That's Dr. Dmytro Pavlenko, who's speaking from Ukraine at the moment, and will talk about telemedicine, a very hot topic in our field right now.
Hello. I thank the organizers for the invitation to share our telehealth experience. I have no financial interest to disclose. I consult patients remotely as a volunteer. This is how 100 years ago people imagined telemedicine in future. But despite the fact that in Ukraine we have electronic passports and driver licenses, among other digital features in our smartphones, our 2022 experience in teleophthalmology does not include use of the state-of-the-art technologies like the artificial intelligence at Stanford or even portable ophthalmic equipment. And let me briefly go through some of the major circumstances that led to a surge in telehealth referrals. Yeah.
Sorry to interrupt, but you haven't shared your slide yet. We don't see your slides.
Oh, sorry for that. Is it fine now?
Yes, one more second.
Can you see the slide right now?
Yes, all good.
Okay, good. Yeah, so at this moment, we have the full-scale invasion of Ukraine that started 6 months ago, and it marked a steep escalation of the ongoing war. And more than 14 million people, which is 1/3 of the Ukrainian population, they are thought to have fled their homes. And in the capital city of Kyiv, for example, half of the population reportedly left the city as of March 10th. And as we described in our recent publication, this full-scale war has affected eye care nationwide, and there were disruptions in several uncontrolled regions. As the civilians, they were sheltering wherever possible, including in the metro stations, and some health services were provided in the basements of hospitals due to constant shelling. On the other hand, hundreds of healthcare facilities have been damaged and over 100 destroyed. At least 14 healthcare workers have been killed and 48 wounded. So the management of ocular conditions has been really complicated by airstrikes and shelling, transport issues, elevated prices, and a shortage of medications and medical supplies. Beside the war-related combat and civilian ocular injuries, people are getting household and occupational injuries. Telemedicine here has been effectively mitigating some gaps in eye care, and it appears to be helpful for mild injuries and in many cases eliminates the need to go to the hospital and be exposed to further danger. But in contrast to more conventional models of telehealth, where trained personnel performs ocular imaging using modern equipment, during wartime in Ukraine, it is generally done maturely on the patient's side, while at home, evacuating or sheltering, or abroad. Patients use cameras of their portable devices, such as an unmodified smartphone or a tablet, to obtain photographs and videos of their eyes and to send them to the consulting ophthalmologist. As in most regions of Ukraine, the internet connection has been good during this time, but real-time videos of the eye are often of insufficient quality. Thus, we would prefer photos or non-live videos of the patient's eye because the resolution would be high and these things can be zoomed in to look into greater details. Some patients, like the man on this photograph, or members of their family, they are even able to avert the upper eyelid when looking for a possible foreign body, for example. There are several options available to receive a teleophthalmic consultation. The Ministry of Health of Ukraine has announced a free of cost hotline. Some hospitals and organizations have provided lists of the contact information of volunteer ophthalmologists in the media. Interest in telehealth platforms has definitely increased, and a few new services have been launched. Also, we are thankful to our colleagues from abroad who have also joined these efforts. Volunteers have created groups and chatbots in Telegram and Facebook Messenger. They quickly gain popularity due to their convenience for both patients and physicians. In groups, a patient can write a question publicly or directly contact the preferred specialist. Chatbots would automatically transfer the patient request to all relevant specialists. Each participating ophthalmologist is on a virtual call almost 24/7 and can respond to the request upon availability, just as shown on the images. Professional societies and medical bloggers also actively use social networks, mainly Instagram and Facebook, to spread awareness about first aid and common conditions, as well as to perform medical consultations. Patients request remote consultations. They are usually not able to receive in-person care. In general, they have external eye infections and minor injuries, and we believe that major injuries are treated in person. Remote assessment and management of ocular trauma is challenging, but these patients can often within minutes receive professional advice using telemedicine before getting an in-person visit and detailed evaluation if possible at all. Some people need help with their chronic or non-urgent conditions or need to change their medications. Let me go briefly and show you a few cases. The mother of a 14-year-old male asked for help as her son had a one-day history of a blurred spot in the center of the visual field of the right eye after playing with the green laser pointer and shifting it and shining it into the patient's eye. On the top left figure, you can see a paracentral defect that this patient drew, indicating that it was blurry for his right eye. I informed his mother about very likely damage to the macula, and they were abroad at that time, so I encouraged them to have a detailed in-person evaluation of the retina. Meanwhile, an NSAID eye drop like Nepafenac was offered as an option, but the mother was hesitant about this drug. A local physician checked this eye 6 days later. The visual acuity at that time was 0.7, and the OCT showed a disruption of ellipsoid zone, as well as retinal pigment epithelium migration in the fovea. 3 weeks after the incident, the visual acuity improved to 1.0, but the RPE defect remained. Even soft toys sometimes can cause an issue, like in the case of this 3-year-old child who had a toy plane hit his right eye, resulting in an oval pupil. Fortunately, they had an opportunity to visit an ophthalmologist to further evaluate the eye. This female was abroad when she referred with a 1-day history of left eye redness after a chemical burn of the left eye occurred with a hand sanitizer. She self-medicated with a decametaxine solution and methyluracil levamisatine ointment, but those are intended for external use. The patient was recommended to stop the current treatment and proceed with prophylactic antibiotic and artificial tears for comfort. In the next case, the daughter of a 47-year-old female with hypertension requested an online consultation due to the redness in her mother's right eye. So the patient had systemic hypertension and a history of prior trauma in her eye in childhood, but since the shape of this lesion looked suspiciously like a laceration, I asked again about the recent trauma and whether the amount of blood was increasing at that time in that area, but she denied both things, and her daughter managed to take a closer photo. As we see, it appeared to be vessels, not a laceration. Accessibility of medicine is high, but it is still limited because thousands of unreachable people are there. They remain without any eye care because they are within sieged or occupied cities. They do not have sometimes cellular or internet connection or electricity. We have a lot of challenges to visualize posterior segment of the eye in a non-hospital setting because the ocular imaging is occurring on the patient's side. In most cases, some modifications are needed. For example, that would be an additional lens or an extra light source positioned just next to the camera lens to achieve coaxiality. Also, there are privacy and legal aspects of consultations when we are using non-licensed telehealth methods, for example, instant messengers. In conclusion, ophthalmic services have been disrupted in many regions of Ukraine during the full-scale war, and teleophthalmology has been effectively mitigating some gaps in eye care. Patients have a variety of options to receive teleophthalmic consultations, and as opposed to the conventional model of telehealth where trained personnel performs ocular imaging using equipment, during wartime in Ukraine it is generally done with no special training on the patient side, while at home, evacuating or sheltering, or abroad. Many disorders of the structures visible externally can be managed remotely, while visualization of the posterior segment of the eye is challenging. Now in Kyiv, we observe higher numbers of in-person visits and lower numbers of remote teleconsultations. I thank every defender of Ukraine whose service allowed me to be here with you today, and of course, thank you for your attention.
Thank you so much for that wonderful presentation, Dr. Pavlenko. It's inspiring to see how you can work in difficult situations and become even more resourceful because of it. So we're running a little bit over time. Unfortunately, we're going to have to cut short the questions and answers section, but I do want to, on behalf of the whole panel of speakers, thank again for you all in the audience for your attention, and thank again the organizers of the KKPI Expo for giving us this chance to speak to you all. So have a wonderful Sunday, and I hope you enjoy and learn a lot of things to bring to your practice.